So frontline Hodgkin's is the disease that keeps on giving in terms of debates. There are lots of ways to treat Hodgkin's frontline. It's a very treatable and curable condition, and that leads to very heated and passionate opinions about what the best way to do it is. And yes, in BSH, there was an oral presentation from the Cambridge group, so George Follow's group, based in Addenbrooke's in East Anglia, that looked at real-world escalated BCOP-treated patients. And East Anglia traditionally has favoured an escalated BCOP approach for their advanced stage patients. And it compared it with an ABVD real-world group, and it also compared it with the RATTLE study population. So it's really a three-way comparison: escalated BCOP, ABVD real-world, and RATTLE results. The RATTLE being the trial that response adapted, but every patient started with ABVD. And essentially what it showed, so in many ways it confirmed what we already know. So we know that escalated BCOP is a more effective anti-Hodgkin lymphoma treatment than ABVD, and it certainly did confirm, both in comparison with the ABVD real world and the RATTLE real world, a significant 5-year progression-free survival benefit. So with ABVD and RATTLE, it was around an 80% 5-year progression-free survival, whereas with escalated BCOP, that rose to over 90%. So, there really is a very stark difference. The overall survival is a bit more nuanced, and this is really where the controversy comes in. A prior meta-analysis has suggested an overall survival benefit for escalated BCOP, but that's been very controversial. And this analysis here, presented at BSH, basically shows that compared to the ABVD real-world cohort, there was a significant overall survival advantage, but not compared to the RATTLE population. Now, why might that be? Well, the RATTLE population is a trial population, so you could argue they were in a better patient group than the ABVD real world. However, having taken part in the RATTLE study, it was a very inclusive study. So I'm not sure personally that argument washes. Perhaps more likely is that as time has gone by, we have had access to better salvage treatments. And the authors make this point in the abstract. And that may make reduce any overall survival benefit that's seen. Of course, you're still preventing relapses with escalated BCOP, and that is a good thing. Relapses are terribly traumatic for patients, not surprisingly. But with better salvage, we may be allowing an improved overall survival for that patient group. The other interesting thing is there certainly did seem to be a benefit when you look at the high IPSS patients. The benefit seems to be greater using escalated BCOP. And I guess this reinforces the approach of quite a few UK centres now of risk stratifying, not just response adapting, but risk adapting up front and looking at the IPSS and perhaps selecting those patients, IPSS 3+, that's what we do in the Thames Valley. The exact cutoff may vary centre to centre, and suggesting an escalated BCOP approach for those higher risk patients, whereas suggesting an ABVD-based approach for the lower risk patients. As I say, pragmatically, that's what quite a few UK centres do now. But you're quite right, there are some centres that will always be more biased towards an escalated BCOP DAC approach, and some centres that are much more heavily weighted towards an ABVD-based approach. In the UK, we're not reimbursed for AVD brentuximab, so that's not really hit the wires, if you like. It is licensed in Europe for stage 4 disease only, not stage 3, but it's not reimbursed in the UK. We will actually, though, internationally get some data of another novel frontline regime for Hodgkin's, and that's AVD combined with nivolumab. As in the US, there's a randomized study comparing AVD brentuximab as the standard of care arm, which is proven controversial, versus AVD nivolumab as the experimental arm. Now that's ongoing, that study, and it'll be quite a few years, I think, before we hear a readout, but we're all very interested to hear what that will show. As I've already alluded to, though, in the UK, most centres now, even if they go for an intensive treatment approach, don't so much use escalated BCOP. We've more or less switched to escalated BCOP DAC, where the procarbazine's been replaced by dacarbazine. And that's thought to be much kinder, potentially at least, on fertility. Now, we don't have proper data to show that the switch was actually based on pediatric data, where COP was replaced with COP DAC and shown to preserve fertility, particularly in males. with no decrement in efficacy. Now, we haven't shown that clinical data with escalated BCOP changing to escalated BCOP DAG, but it does seem to make sense. So most centres in the UK have switched to that.